Okay. Welcome to the Primary Care Commissioning Committee. It is our last meeting as the CCG will be no more at the end of June. So welcome everybody for listening and to people attending the committee today. We have got apologies from Sandy Buchan, Brian Hughes and Zach McMurray and Greg Fell, who normally attends. So I think that if we can start then with the, I've gone through the apologies for absence. Jackie wanted to say something.
Can we just note that Abigail Tebbs is standing in on behalf of Sandy Buchan, so just for chorus sake to note that.
Okay, thank you. Yes, I should have mentioned that. Right, so are there any declarations of interest? I know we've got the general declaration of interest, but any declarations of interest in relation to this agenda? No. I think Amir has in terms of the estates, hasn't he, and Amir is going to, Afsal is going to be a bit late attending.
I think because we're only considering the hub proposals, Amir doesn't have a conflict of interest for this.
Okay, that's good, thank you. But if anything comes up in our discussion which takes us into conflict of interest, can you please draw my attention to it so that we can note it and the type of conflict of interest that it is? Thank you. We haven't had any questions from members of the public. That's correct, isn't it, Karen? We haven't had any questions. So if we can go then on to approving the minutes of the last meeting. So if there are any amendments, inaccuracies on page 1, page 2, page 3, page 4, page 5, page 6, page 7, page 8. Okay. So if we can then look at, so if we can take those as approved then, Karen. I've said, I haven't introduced myself actually, which is remiss because I'm going to try and remember to remind people to introduce them. So I'm Chris Niels, I'm a lay member and I chair this committee. Thank you. So going on to the matters arising, as this is the last committee then, these will all be recommended for closure or the attention of in the next structure, probably at place level with Sheffield, who will be responsible for these areas of work. But I do want to just go through them. So the locum spend, which was a question, Abby, that's now in the primary care report, isn't it? The update on that, which is in this meeting's agenda.
It is, yes.
Okay. Sandington Medical Centre is on the agenda for today, which will be closed or pass through it to the next structure. Digital update programme.
We have a presentation scheduled for the meeting in private around digital services for our people.
Okay, thank you. And then these two questions were from Trish, again, about the digital access and website and so on, which we will still, Abby, pick up in the private meeting. Is that correct?
The two questions that Trish had asked about, we've got a response in the matters arising from Tom around the shared care record work, Trish, that the information isn't available yet, but we've asked the project team to make sure that it's sent to Healthwatch as part of the information sharing engagement process.
Okay, Trish, thank you.
And there's an update also on the website, on the progress of the website work as well, because that's an ongoing programme.
So the one on the next page about update. So an update's been circulated to members. So Abby, did you want to say anything further about that? There'll be an update at this meeting as well.
Sorry, Chris, which bit are you?
It's the digital programme update. And
the digital services for our people is the presentation in the private meeting.
Yeah, okay. Okay, so all those will be presentation at the private meeting.
No, just the digital services for our people.
Sorry. So the last one is reflection on primary care. So we shared the annual report, and the final report is been added to the agenda for this meeting. So that'll be closed as well. Okay. Is there any other matters arising that haven't been covered on these that anyone wants to pick up? Okay, so if we could go then on to the primary care capital transformation project and the pre-consultation business case. So I think there's Mike and Lucy want to contribute to that. Mike, you want to introduce it? Is it Jackie as well? Yeah, sorry.
All right.
Order. Are you introducing it, Mike, and then handing over the other way
I think Lucy's going to introduce.
I'm going to introduce, sorry.
Oh, sorry, Jackie.
So, sorry.
Mark, you had a question before we start that?
Yeah, I just want to check, because we've had a paper circulated late for this. I'm assuming that in addition to the paper that originally came, that we'll be picking up on that as well.
Yeah.
Thank you, Jackie.
Yeah, has everyone had a chance to look at it? It's quite short. There's, is it 4 or 5 bullet points? Has everyone had a chance to read those that came through earlier? I've got some thumbs up. I'll let you introduce it, and then before Mike says anything further, I will just check that you've all had a chance to look at that and give you a couple of minutes. Jackie.
Right, thank you. So I'm Jackie Mills. I'm the Director of Finance for the CCG, but I'm the Senior Responsible Officer for Estates as well. So I recognise we've got a significant amount of information here, so I just wanted to outline how we propose to go through this, but we will allow plenty of time for comments and questions. So as a reminder, you'll remember a strategic outline case for the Sheffield Transformation Hubs programme was approved by this committee in January 22. We have submitted that to NHS England an improvement, and I think we've substantially worked through most of the feedback we've had on that, so we're just waiting for final approval of that. And I just wanted to remind you just briefly that, you know, this was capital funding that was awarded to South Yorkshire on the basis of proposals worked up by practices in South Yorkshire. So it was the basis of a bid that was submitted that didn't really go anywhere until someone kind of picked up as part of the government announcement on the new hospitals programme. There was some primary care proposals. So we were approached and offered the funding on the basis of the proposals that we had previously worked up. And it is those proposals that we are expected to work up if we want to access this funding. The funding does have some strict national criteria associated with it, which it's fair to say that those criteria are really focusing the progress of this programme. So just reminding you that the funding must be used for the purposes as laid out in the original bid. So we can only use it for, in this case, for the transformation hubs that we are proposing. It's not within our gift to decide that we want to use it somewhere else. If the money isn't used for the purposes that we've outlined, it will initially be returned to South Yorkshire for for the ICB to see if there's other projects that were in that scope that could be progressed or returned to the Treasury. We need to meet the Treasury requirements, so there's a national process we need to go through in terms of demonstrating that the schemes are affordable, both in capital terms, but also in revenue terms, so the ongoing costs of running the hubs, that they offer value for money, and there is a very technical process called a comprehensive investment appraisal process that we need to go through. And we need to demonstrate that we've had a robust process for options appraisal. All of that is laid out within the strategic outline case that we've previously approved. There's a requirement that any new buildings that are built from this capital are in public ownership. So given that the CCG was unable to own buildings, we've been working closely with Sheffield City Council as a potential delivery partner for them to own the premises and run them. And then the final criteria is that the buildings need to be completed by December 23. And that is the main driver for the very tight timescales we have around the consultation. And Lucy will outline that in more detail when we get to that. I would say that deadline of December 23 is extremely tight. We still assess that it is achievable, but there's little leeway for slippage built in for that. So following the approval of the strategic outline case in January, we undertook a pre-consultation exercise, and that was undertaken between mid-March and mid-May. We need to recognise that during that period we had the local elections, and so had to recognise that some of our normal engagement was a bit constrained by that. But notwithstanding that, we did run the engagement exercise, and Lucy will feed back the outcomes from that engagement work. In line with the NHS requirements for considering significant service changes, we've produced a pre-consultation business case. So that is drawn a lot of information from the strategic outline case, but there's a different purpose for the pre-consultation business case. It has to meet the tests of NHS England in terms of that considering service change. So the pre-consultation business case addresses all those requirements, and Mike will outline the business case and the key changes that we've made to the proposals in light of the discussions with practices about their current thinking, and in light of the engagement work that was shared with them. Lucy's going to outline the proposed consultation plan, and then noting, as you said, Chris, we took these proposals to the Health Scrutiny Subcommittee of the Council on Tuesday afternoon. So they received the same information and have provided some feedback. I think the suggestion we were going to make, Chris, is that we pause at that point, just to allow people to either read for the first time or reflect on that feedback. But Abby will then take you through that feedback and our proposed responses to that. And then, as I said, there'll be time for questions. So if you're happy with that as a kind of proposed way of handling the meeting.
Yeah, I think that's really important, Jackie, because I think there is some confusion about a pre-consultation and a consultation. And it's, to me, those business requirements in the initial document, but it's, it doesn't mean that the consultation isn't a real consultation, the full consultation as well.
Exactly.
If I can give people a couple of minutes just to have a look at.
Well, can we go through the different bits, and then when we get to the health scrutiny bit, we'll pause at that point.
Okay, that's fine. That's fine. Yeah.
Yeah. Sorry.
Carry on.
So we have to just ask Lucy to summarise the outcome of the engagement work.
Yeah, thanks, Jackie. Sorry, I couldn't work out how to unmute. I'm Lucy Escher, Deputy Director for Communications and Engagement and Equality for Sheffield CCG. I know that you've all read it, but I think you are presented with a lot of information, so I will just pull out some of the highlights. So the report, which I think is Appendix 2, summarises the engagement findings. So we engaged over a 2-month period, and as Jackie's already said, due to government timetables, that we had to carry out engagement during the pre-election period and Ramadan, which was far from ideal, and it did hinder our ability to do large-scale open communications. And we did get around that though. And we actually had a really large response rate. If you consider it at sort of a northeast population level, when you break it down at practice level, sometimes it's not great. But we did hear from over 2,000 people, which is a pretty robust sample size. We couldn't initially run public meetings because it wasn't a pre-election period, but following feedback at Scrutiny and from Health Watch, Trish, that actually we asked the community groups on Health Watch to run some groups for meetings for us, and actually we got really good attendance from those. So overall, the views were mixed, and they were very much dependent on people's practice and what sites they were commenting on. And the pre-consultation engagement was done on the 5 centres, where the consultation is going to be done on the 4, which is all outlined in the pre-consultation business case. So the majority of people told us that they agreed that their area needed more investment, but the majority of people also told us they weren't willing to travel further for their primary care, and the majority told us they couldn't get there if indeed their practice was relocated. There was no consensus over whether the proposals were a good idea or not, but slightly more people disagreed that they were a good idea than agreed. Vast majority of people liked the idea of having more services co-located with their GP. The 2 services that stood out really were diagnostics and bloods and mental health, so access to talking therapists. If in the analysis of the qualitative analysis of the open-ended questions and the questions that we got either via email or at the public meetings, the big concerns that came out, which does correlate with the quantitative analysis, is distance to travel. So that was a big concern. Issues with public transport, either availability of public transport and also the cost of getting there. And people were concerned on behalf of others as well, which vulnerable people, so single parents, older people and people with mobility issues. So they were concerned on their behalf about how they would get there. And also a really strong theme that came across was concerns over current provision. And people, a lot of people weren't happy with the current provision provided by their practice. All this data, so that is very, very high level. All this data was shared with practices. So initially we did an interim analysis, which was about 10 days before the engagement closed. So it's pretty much most of the quantitative analysis. It wasn't all the qualitative. So we shared that with practices, and then we shared the full report with practices to inform their decision about whether they wanted to stay in or withdraw from the process. And then the views have gone in to shape the pre-consultation business case as well. So I don't know if you want to take any questions there, or we're going to take them at the end after we've done all the other papers. I don't know. It's preference. Sorry, did you say Jackie? No.
Shall we go through, Chris? You happy? Yeah. Okay. Thanks, Lucy. So if we hand over to Mike just to take us through the pre-consultation business case and the changes to the proposals that we're now looking to go out to consultation on.
Thank you, Jackie. I'm Mike Speakman. I'm the project lead for the project on behalf of Sheffield CCG for the transformational hubs. In line with Lucy's, I'll take the document as read rather than go through it in detail. So just to highlight a few points. The document, the pre-consultation business case, is prepared to comply with the requirements for proper consultation. It includes the opportunity to adjust our plans and our final proposals before we get to the implementation stage, and that's really important. What the document does, it describes the emerging proposals and makes the case for change. It builds on the work that we've done previously and demonstrates progression from our earlier proposals that we saw in strategic outline case, and takes those into account. And I'll outline some of the steps that we've done to reach this stage. I think it's really important that we learn from the early engagement, and that it still identifies a number of key work streams that we do need to progress concurrently as we develop our plans. But what we've seen and what we've been doing since the business case We've been working with our delivery partner, Sheffield City Council, who have appointed a principal supply chain partner to work up in more detail the requirements and the proposals that we have to make sure that what we're consulting on is actually deliverable. So there's been significant work around the overall affordability, the site investigations, and we've been working with practices just to confirm the terms of a feed of what a relocation would be. We've updated the work in the strategic outline case, which you'll remember will have shown or did show that we confirmed preferred way forward and we confirmed viability in the 5-case model. We've now firmed up the site proposals from the long list that we had in strategic outline case. Some of that is based on technicalities and some of that is based on further work around site investigations. And some of the sites were not available that we took forward. So we have only been able to consider viable sites. We've also shared with practices the financial reviews that have been undertaken on the basis that we made a genuine offer to all practices that they would have all of the information required to help them make an informed decision. So with the confirmation of the proposed sites, the confirmation of the offer to practices and what it would mean for them and the terms that they would be occupying upon, the financial reviews, and not least the early engagement communication feedback has been really, really important and valuable to practices. And that's helped practices confirm their intention, whether they wish to remain within the programme for consideration to move to a hub, subject to the consultation process, or whether they would prefer to stay where they are and they've decided that's not for them. And so that what has enabled that next stage is give us the firm consultation proposals about which practices will be moving to which sites. We have had some practices have said it's not for them, and that's their decision, as there's no consultation required on that as a status quo. They'll remain as they are and delivering. And we have had 2 practices have confirmed their intention that they would wish to stay in their location, their current location, and develop their site further. And that was always modelled as the intermediate option. The business case sets out the number of permutations that there are, and there's 72 permutations of schemes were listed that were formally considered. Behind that, there's many other options about what we'd do on each of the individual sites that we'll work through with the practices. We've taken a very strong lead from practices, continue to do so around shaping these proposals. There is no sort of onus or pressure on practices to comply with this as a requirement in any way. So what we've been able to confirm is affordability, both in terms of capital and revenue, and get to the stage where we are now able to present formal proposals for change and that we're able to consult on those. And we'll continue to do work in the background on those, given the timescales that we have. But again, that is not a commitment that we will enter into any of these schemes unless we've gone through all the proper processes. Okay.
Thanks, Mike.
Sorry, Mike, is it worth just highlighting some of the changes that we have made because they're brought out in the in the cover report?
Yeah, I think in terms of page 6 of the paper is probably the easiest table and quickest to refer to, rather than me sharing a screen and the material that's not in the pack. So on page 6, 4.3 just outlines the changes that we have. So in terms of practices that have confirmed that their interest to move forward, for Foundry 1 Health Centre, we have Burn Surgery and Sheffield Medical Centre have confirmed their continued interest. And that would be on the basis that they would relocate to a site on Spittal Street, which is next door to Sheffield Medical Centre and is indicated as a 4-minute walk from Burn Surgery. As part of that option, as modelled in what's called the do maximum, Pittsmore Surgery have decided they would not want to move to a potential new health centre, and that removes the Catherine Road site, which was the only potential site that was suitable for all 3 practices, rules that site out and confirms that Pittsmore wish to pursue a development of their existing site. In terms of Foundry 2, we have Page Hall Medical Centre and Upwell Street Surgery proposing to move to a site on Rushby Street, opposite the Furvale Community Hub. And there's no change. That was the preferred way forward that was identified previously, and that's been confirmed by practices and all of the work that we've done to confirm that we have a viable scheme. In terms of SAPA 1, we have Firth Park Surgery, Dunwick Road Surgery, part of the Green Cross Group practice, and Shire Green Medical Centre, proposing to relocate to a new hub located alongside Concord Sports Centre. The Sports Centre is in the programme by Sheffield City Council for redevelopment, and the proposals on site have been developed that both of those work in synergy. So there would be a link between the new health centre and the new sports centre when that's developed in a later phase. As part of those changes that we provided, and there was a significant amount of determination by the early engagement communication work, Elm Lane practice have decided not to move to the proposed site, and that is predominantly around distance. And Norwood Medical Centre was always modelled in this particular scheme as a do intermediate, that they would prefer to develop on their existing site and increase capacity. And that's been confirmed by them. What we did do, obviously, part of that was model them into a do maximum so that they were provided the same opportunity and treated exactly the same as all other practices, but that was always their intention to remain as they are. So that remains as the preferred way forward, but Elm Lane and Norwood are not included within the health centre proposal. And then SAPA 2, we have the healthcare surgery, the other part of Green Cross Group practice, Buchanan Road Surgery and Margaretson Surgery, part of the Ecclesfield Group practice, would be relocating to a site on the corner of Buchanan Road and Wordsworth Avenue, opposite Anster. Southey Green indicated that they would prefer not to move to the new health centre, and therefore they will remain in their current location. And then finally, not part of the consultation, but is included, we'll just touch on why it's not included. We have had changes in city centre, and we only have Clover City practice and the Mulberry practice currently indicating as part of a new hub, following Devonshire Green deciding that they and their branch at Hanover would not be relocating. And that changed the nature of the building, or the particular building that we'd identified as a potential location. That building is too large and no longer available. So we are working with Sheffield City Council colleagues to identify a city centre site, potentially on High Street, Fargate area, so very central, highly accessible, for the relocation of those practices. But because we don't have a particular site confirmed as yet, we don't have sufficient detail to be able to confirm in a consultation.
Thanks, Mike. And it is probably worth just mentioning, just in terms of that last bit of not consulting on the location for the city centre site, we do envisage that will be a refurbishment of existing property, given the makeup of the city centre. So there is a bit more time, because we won't have to do a brand new build to be able to do that. So the consultation framework for that hub allows that slight slippage. So can I hand back to Lucy just to outline the plan for the consultation? Sorry, Chris.
Can I just ask Mike, while we were talking about the specifics of that, what does it mean for those that go for the intermediate option of, updating their premises? How do you financially allow for that? It's obviously not going to be the same cost as building a new building.
No, it was identified as an option. So all of the options that were included were modelled within the strategic outline case. In the case of Pitsmoor, it was identified as their intermediate option. It's why we had two sites. That would mean a development on their existing site, some reconfiguration, some addition to that. That is to be confirmed, but it will be taken forward through the normal capital routes, with the practice making a contribution, is our understanding. It's still to be confirmed, but it will be separate and taken forward as a separate contract, not part of the Section 2 agreement that we do with Sheffield City Council necessarily.
Okay, thank you.
And same for Norwood, I should add.
And can I welcome Amir to the meeting? We're on the first item, Amir, and just going through the feedback from the pre-consultation. Thank you.
Thank you, Chair. Apologies for being late. Day job and all that.
So Lucy, can you take us through the plan for consultation?
I can, thanks. You may notice with all the reports, there's a little bit of duplication because all the reports are designed to be standalone documents. That's why this consultation plan also has the background to the programme. Since we've written the report, we've actually commissioned the Consultation Institute to work with us to produce a readiness for consultation report, which they'll look at the pre-consultation business case, they'll look at the consultation documents, the survey and the plan, just to make sure that they're as good as they can be and we're doing everything right by the public and meeting our legal duties. So just to provide that assurance, which we will provide the feedback to committee. The plan has been shaped by a comms engagement workstream, which is part of the governance of the programme. It's been back and forth a few times, but I'll just, again, like I did with the pre-consultation engagement, I'll just take you through some highlights. And hopefully you will see that we do cover a wide range of methods. So it's very much not one size fits all. We have got surveys and we've got the usual online surveys, and we'll have printed documentation about what the surveys on. We'll also commissioning voluntary community sector organisations to get to those marginalised communities, and they will take them through the survey as well. And we're also commissioning an independent company to do at least 1,000 surveys in each of the 4 health centre areas. So that will either be by telephone or face-to-face. And we haven't finalised that yet, but probably a mix. So we've got a series of public meetings which will be publicised far in advance. We're going to have them at the start, in the middle and at the end. And actually, if people invite us to other meetings and we need more, we'll have more. And we'll also go to the local area committee, which is in the northeast of the city. So all the materials and the survey have gone to readers panel for comments, and the survey will be piloted before we launch it, just to make sure that actually the questions couldn't be viewed as leading, or actually they're easily understood. So all those methods, including, I think I haven't talked about, but we'll get comments on social media, we'll get emails. All of those will go to the independent research company, and they'll go into one data set. So all of the comments, doesn't matter where they come from, will be analysed by the independent company. So they'll look at commonalities and differences by practice, they'll look at health centre, then also analysed by demographics, which is standard, but they'll also look at actually in the method that views came back as well. So we'll see if there's a difference between those people that were contacted randomly via telephone to those marginalised communities that were spoken to through voluntary and community sector groups. The draft consultation document is within the consultation plan as well, which I think currently it's about 25 pages. We'll get that designed and printed, and we'll hand out in public areas. So that's a summary of the pre-consultation business case, and we're going to do a leaflet, which will be a summary of the consultation document. That will be about 8 pages, and we'll get thousands of those printed, and they'll be all over the place in pharmacies and practices and libraries and community organisations, and hopefully pubs and cafes and things as well in the area. And then the survey is also attached as well for any comment and approval. I think I will finish there. That's okay, and hand back to John.
Thanks, Lucy. So the final bit is just to note, as we said at the beginning, so we took this information to the Health Scrutiny Subcommittee on Tuesday afternoon. So Abby kindly stood in because I was unwell and went along with Lucy and Terry as our chair, as our CCG chair. So the comments from that meeting have been circulated yesterday. So before we go through those, do we want to give people just a couple of minutes pause to read through them, unless people tell me that they're comfortable that they've read through them? Should we just pause for 2 minutes?
Has everybody seen them, received them, so you can read it? So okay if I just give a couple of minutes to have a look at them? I'll do that then, Jackie.
Does everyone feel like they need any more time?
Okay, so getting, I don't know.
Sorry, Chris, I was just going to ask Abby just to get, because she was at the meeting, I was just going to ask Abby to, because I think it's fair to say that there was quite a lot of feedback in terms of the meeting, some positive, some negative, some quite constructive, some suggestions about how we might amend some of this. So I just thought it'd be helpful for Abby to go through the main bits of feedback and some of the proposals that we put forward during the meeting, and then open it up for people's views and comments on that. Abby, are you all right to take us through?
Yes.
Abby, have you already introduced yourself? If not, or do you want to do it again?
No, I haven't. I'll do it now. I'm Abby Tebbs. I'm Deputy Director of Primary Care Contracting Digital Estates at the CCG. So as Jackie said, Health Scrutiny Subcommittee met on Tuesday, the 21st of June, and the paper that members have just had time to read, obviously, is the feedback that they provided. So the first point in their feedback was around some concerns that there may be some inaccuracies in how the service data was analysed and presented, and in particular a question about whether the net agree and neutral responses had been counted correctly in the report. So we gave an undertaking that we would make sure that those calculations were correct, and that the engagement report was amended if necessary in accordance with them to reflect the correct calculations of net agree and neutral responses. So that is happening now. The second point was around the committee were disappointed that the carry forward options from the long list haven't been included in all cases in the consultation, and they would like PCCC to look carefully at whether the carry forward offers would be viable. This, I think, actually forms part of the pre-consultation business case and the explanation about which offers have been brought forward to consultation and which ones have excluded, and how the option appraisal was conducted is set out in there. And I think if there are any more questions, Mike can give some further clarification on those points.
Thank you, Abby. I think this relates to page 53 of the pre-consultation business case, and this is in the standard format for HM Treasury, where you consider the options against a number of criteria, and therefore is part of an assessment of whether a scheme is either discounted, not taken forward, or carries forward into the outline business case stage. And what we've identified is in green in that table are the preferred way forwards. I think the question is around why are we not consulting on those that are carried forward? And I think that's the difference between what is a proposal and that is actually what is taken forward as another option for a further evaluation at OBC and FBC. And I think it'd be highly unusual and I think very confusing if we would consult on the preferred way forward and those that are to carry forward. So I think it is standard process. I think it's about an understanding of how that the green book for business cases is developed. So we need to consider them. So we have got something else to compare, that making sure that the preferred way forward is the best option in the 5-case model, which is different to consultation.
So just to clarify then, at the stage of the pre-consultation, we were looking at what the options would meet other criteria that are, mandatory criteria. So it would be misleading to put them forward to the next stage when you know that they're not viable, if you like, because they don't meet other criteria. So have I got that right?
It is. So we consult on the preferred way forward that we have identified. Yeah.
And that applies, I don't know if I'm jumping ahead, actually, probably, I won't make my next comment.
Thank you. And it may be that we need to make that to further clarify in the final documents how that process works and why it's presented in the way it's presented. So we'll review that and make sure it's as clear as it possibly can be. Committee was concerned that the pre-consultation business case didn't adequately address or mitigate negative impacts identified through the equality impact assessment, or negative patient responses from the pre-consultation engagement around ability and willingness to travel further to access services. I think there are 2 points here, and Lucy, I think you might, I don't know if you wish to come in to give some further information, but one is about the difference between obviously the pre-consultation engagement, which is also picked up later in this feedback, and the formal consultation. So we, at this point off, while we were seeking to gather sort of early views with the pre-consultation engagement, what we are seeking to do now is complete the formal consultation and hear from as many people as possible about the impact on them of the proposed changes. The other is that part of what we were doing at the same time as this is identifying any additional impacts on patients and develop our mitigation, which will then be presented within the outline business case and the full business case. The proposals at present don't seek to fully address that mitigation. Lucy, is there anything else you wanted to add?
No, that's a very good answer. Per se, the equality impact assessment does actually list some suggested mitigations, but at this point, because we haven't made the decision on whether we're going to go ahead with proposals or not, obviously we can't do those detailed plans on the mitigations, but we'll be working on those in parallel, you know, during the consultation to really look and cost those whilst asking for more possible impacts, positive and negative, during the consultation. Thank you, Lucy. And then the committee was also concerned about the low response rate to the pre-consultation.
Can I just make a point about the last point, Abby? So in terms, I mean, equality impact is really important, as well as mitigation, and we've got some really, Lucy was saying, marginalised groups, if you like. So, and I recognise the efforts that we've gone to capture that feedback. So I understand, and you might have already said this, that'll be done then, the equality impact assessment, on each of the bases or centres. So it's not going to be the overall plan one, although there may be some in terms of the overall plan. Is that right?
Yeah, there's 4 already in the pre-consultation business case, and we've done one for each of the health centres. But before they make their final decision, there's a legal duty that practices carry out an equality impact assessment. So any practices that actually do want to sign up, then they need to be able to understand the impact it will have on their patients. And obviously the decision-making committee, which will be the ICB board, and sorry, I should have said actually as part of my consultation plan, they'll want to see those, or their subcommittee that is responsible for equality will want the assurance that practices have done that as a commissioner of primary care.
So this is important. This is about going forward and the next steps, isn't it, with the full consultation. And I mentioned the ICB board. Jackie, did you want to say something about? No, okay. Go back to Abby then.
Thanks, Chris. So the committee was concerned about what they felt was a low response rate to the pre-consultation engagement, which is around 2% of the total population who were registered with practices who are exploring these options, and they felt that may undermine the findings of that engagement and possibly run counter to the NHS 4 tests for service change, the gunning principles around strong public and patient engagement. I think that we have made it clear, and we'll review that the pre-consultation engagement we undertook was that what was a general engagement with those populations. What we are now undertaking is the full consultation, and as Lucy's outlined, we've got a full plan, and what we want to do is hear from as many people as possible who are registered with those practices, so that we have as high a response rate as possible, and we can take a full view, take a fully informed view of what those what patients and the public in those areas feel are the important factors that need to be taken into account.
Yes, it's okay. I can't put my hand up because I'm a host, but can I come in there? So yeah, we will. The consultation will at least double the response rate. So we're going to go for at least 1,000 in each health centre, but hopefully more. But actually, it is seen as a gold standard for any sort of community research or social research is 1,000 for a population the size of Sheffield, so 600,000. So for the northeast of 100,000 to get 2,000 responses actually seen as a really statistically reliable sample. It's mixed methodology, it's not all random or quota sampling. So from a purist perspective, it doesn't fully stand up, but yeah, it is actually a really good sample size. It sounds odd, doesn't it, because it's 2%, but actually, and it is seen as, you know, in terms of making interpretations and generalizations for the rest of the population, it does stand up.
Judy, you wanted to come in.
Yeah, I don't know if I'm better weighting it in one way, but in the index it refers to quality impact assessment, not equality, although that's there as well. But I can't see a quality impact assessment, and I think it would be really helpful in terms of the business case, having that completed, so that it you know, that will inform, I would suggest, then some of the survey questions as well, and the way that that's put together. And I think it would help address the concern that was evident in the pre-consultation around patients, the public being concerned about not being able to get a GP appointment, which I appreciate is kind of a separate issue to what this is about, but I think that would help in that way. And I've got a question about sort of some of the methodology, but I'll save that for later.
Thanks, Judy. Abby.
Do you want us to pick that up now, Judy, or pick it up as part of the conversation?
Yeah, probably as part of the conversation.
Okay. Yeah, all right. So the committee was also concerned that travel times to the new sites hadn't been properly considered, and this was twofold. The first one was they weren't certain that some of the figures that were within the report were accurate. And they gave a couple of examples. So we have undertaken to double check that those travel times that are cited in the report are correct and are reasonable assessments of walking distance, for example, and that they are allocated to the right schemes. So there's an accuracy check to be done. And the second part of that was just in general about taking into account travel times. There are within the report tables which indicate what we think the estimated travel times or impact on travel times would be. But I think it's also important to point out that the focus of this must be on travel times from where patients live rather than from the existing practice, because we know a practice's catchment is quite, practice's registered population is spread within its whole catchment, and therefore we need to indicate what the impact is on patients or those areas where that practice's population is concentrated, and those are what's presented in the chart. So we will make that clear as well. The The committee were also disappointed that travel by bus wasn't considered as a factor in identifying suitable locations for the new sites. It was part of the options appraisal, how accessible the sites were by public transport. So we need to make that clear. And then obviously one of the factors to explore in terms of mitigation around travel times could well be whether there is any opportunity to improve or increase access by public transport to those sites. And the committee were concerned that the proposals didn't address the fundamental issue facing patients trying to access primary care, the lack of GP appointment availability. And you touched on this, Judy, just now. They are, to a certain extent, two separate issues. However, what we are seeking to do by improving practice facilities is improve access to appointments with clinicians in primary care, because and that's twofold. One is that there should be an immediate impact because practices will be able to have the space to accommodate additional staff within practice or operate additional clinical sessions. So we know across Sheffield at the moment there's a huge pressure to find space for additional roles, staff within practices, and similarly to accommodate staff from other services such as IAPT within primary care networks and practices, and having the additional space available within these within new health centres would we hope have some immediate effect on that, but also have an impact on longer term potential for recruitment and recruitment and retention of staff within those practices and those areas. So it is seeking to address in part that fundamental issue about ability to access appointments within primary care, as is, I think it's worth saying, a lot of the other work we are focused on this year alongside the development of the progressing these proposals for the new health centres. The committee were also concerned that the...
just a minute, Abby, Trisha's got a hand up.
Oh, sorry, I can't see who's got their hand up at the moment.
I'm sorry, I'll bring my hand down until Abby's finished, because I'm not quite sure when we're actually going into general discussion or just particulars about the Scrutiny Committee. So I'll take my hand down for the moment. Thank you. Okay.
Yeah, and then pick it up during general discussion. Okay. So the committee was concerned about that the proposals would result in an increase in travel, which would run counter to the city's ambitions around carbon reduction and also 15-minute neighbourhoods. I think that there are 2 points here. One around carbon reduction, which is twofold. I think the first is about factoring in the environmental footprint of our general practice buildings themselves, and that which will be significantly improved in these areas if the proposed developments were to go ahead, because these buildings would be carbon neutral. The other one around travel times, which needs further work, is that it assumes that every person who travels to one of the health centres will be travelling further and by some form of motorised transport to reach the health centre, which won't be the case, because there will be people who actually end up living a lot further to the health centres, as well as people who are affected by living further away. And in terms of the 15-minute neighbourhoods, we intend to ask the committee for further information on those ambitions, because they are not part of the joint work that we are currently undertaking within primary care. So what we need to understand further is what those plans are and how they fit with primary care networks. Because obviously the plans we have are predicated on practices operating within primary care networks, as determined by NHS England guidance and aspirations for providing services for those populations of around 30 to 50,000 people. The committee also thought the consultation document should be clearly and informatively set out, making clear how the consultation is different from the pre-consultation engagement process and some of the upfront issues and concerns that people had during the engagement that we could be very clear on how we're responding to. And there were some really helpful comments from people about how we could maybe clarify that and deal with some of those immediate concerns people would have and make the responses or the answers to that more apparent in the document. So we have agreed that we'll pick those up and edit the document accordingly to try and make that as clear as possible. And finally, a number of committee members are going to take part in the readers panel, which will review these documents before they go to translation and print.
Okay, so Mark's got his hand up and Trish has a point from before. So this is a chance for us to raise specific points about the whole information you've had about the consultations and the proposals and the feedback, and also to the specifics that have been raised through the Scrutiny Committee. So if I can take Mark first and then come to Trish, is that okay?
Okay, thanks. Two things. First of all, this is obviously my opinion. I think it's really helpful that we've got views from the Scrutiny Committee just before we disappear as an organisation. I mean that sincerely, actually. It's not. Sorry, my name is Mark Gamson. I'm a lay member on the Clinical Commission body. So I do think it's helpful to have these. Having said that, I think clearly, as I think, Abby, you're implying, we would need to, and we haven't had time to do that yet because this was only a couple of days ago, but we would write a formal response in terms of the issues that have been raised. So I don't actually think that we need to spend a great deal of time sort of thinking about trying to solve some of the, respond to some of the challenges that this committee has raised, because those will need to be responded to formally in writing. And then those, I would imagine, will be a public, available publicly in terms of how we're responding to these, because this is a public committee. I think what it does identify, which is a challenge for us, is in between writing the formal response and it being published, I suspect we will disappear as the clinical commissioning group. And so this highlights sort of some of the governance problems that we've got about this issue as a whole. The second issue that I just wanted to raise is more generally to do with the paper. And I suppose it's for Lucy. I think I welcome the draft consultation document. I do think, and I know we picked this up in the Strategic Public Involvement Experience and Equality Committee in terms of frequently asked questions. But I do think if, as much as we can, and being advised externally by the Consultation Institute, we really need to try and make it very clear to the public about the constraints that we're operating within. And this is one-off capital money, not revenue money. And if my personal view is, although we've produced FAQs, I do think we need to have that upfront if we can in the document, because it's also something quite clearly that elected members are concerned about. And we have to be quite upfront about the opportunity that's presented here in terms of funding, the constraints that are upon us in terms of the timescales that we have, and indeed how we can spend the money, and the fact this is not revenue money and won't help solve bigger issues such as those around general practice and its funding. That's it.
Thanks, Mark. We thought we'd address the capital revenue bit in the consultation document, but we'll have another look. We thought, yeah, we had covered that, but yeah, it's quite hard to talk about capital and revenue in plain English, I think, and get the message across, but we'll have another look. Thank you.
Thanks. Jack, well, Trish, do you want to come in first and then Jackie? Or is yours in relation to that last point, Jackie? Okay, can I let Jackie go first? Thank you.
I was just going to come back to Mark's point about timing and the role of Scrutiny Committee. So obviously Scrutiny Committee have a really important role in like overseeing our plans. So and I think, you know, it's really helpful for them to turn around their questions in a really short time scale. And yes, you know, it's difficult because we are transitioning from one set of governance to another. I suppose the reason for taking time to go through those comments and the potential responses is to just give this committee assurance that, you know, we think we either have some responses or yes, we recognise there's further work to be done, or, you know, yes, we can amend the documentation in light of some of those comments. So it was really just to provide quite a assurance to this committee before it ceases to exist that we're taking those comments seriously and have a plan to address them.
Okay, thank you, Jackie. I agree. I think that it's really important to have the scrutiny across organisations, and, you know, the key points about that engagement, the public, patients around these issues, and the clarity of the purpose of doing this, it makes a big difference. And certainly I think our practice in the CCG has significantly developed over the last 2 and 3 years. So just, you know, hearing from Lucy about working with Health Watch, engaging with those community groups, that makes a big difference, that you are hearing from people that may not necessarily contribute through other routes. So I'm really pleased we're doing that, and we'll be considering them further in the consultation, definitely. So Trish, you wanted to come in.
Thank you. My name's Trish Edney, and I'm the Health Watch representative on the committee. My concerns always are the fact of you're not going to have much time to make many changes following the consultation, but you have got time before the consultation on your pre-consultation engagement results to actually make it clearer about the travel, about the buses, and about possible car parks at these hubs. If I can't get by bus, can I park my car? I know the council want us to be carbon neutral. Well, I've got a plug-in hybrid, but am I going to be able to park it to get there? And you really want to be addressing the problems that the patients have already shown you that they've got in the engagement, that they've got problems about getting there. They've got problems about not wanting to have to walk down a certain road when they didn't have to walk down that road. Those are the kind of things that are going to worry them. And yes, perhaps emphasize that they're going to be further away from the surgery, but some other people are going to be closer to the surgery. But I think, you know, you need to actually think about what you've heard from the engagement so far to put out to the consultation, so you don't get negative again about travel and buses and car parks and distances and moving. Okay,
does Mike or Abby want to respond to Trish's point? Or
if I may, absolutely, Trish, thank you for those. I think we have addressed them. I think what we need to do is just make sure they are brought to the fore. And you're right in reflecting, and I'm not trying to give a biased opinion, but you know, there are many issues with our current practices, including accessibility and for many other reasons. And accessibility isn't only determined by distance, but in terms of parking, there's very high standards for parking now on new buildings that very few of our existing buildings do. And we will work with service providers to see what we can do about improving public transport. But the point that's come through loud and clear is we work really hard to try and find sites on existing public transport routes. They are not available. We're densely populated, and it's far easier to change a bus route to serve a site than it is to find a site on an existing bus route.
I didn't see it, and maybe I didn't read it well enough in the proposals about car parking for patients and disabled car parking. Those are the things that you need to be. It would be really nice because a lot of surgeries haven't got any car parking, and if you're actually able to say your new hub, this new surgery will have 3 disabled car parking spaces and enough car parking spaces for X and others.
Yeah. I mean, typically, if I could just illustrate it now, we work on 2 car parking spaces per consulting room. So some of our practices will now have provision of over 30 car parking spaces, whereas at the moment we're getting 10, 12.
It doesn't, maybe I didn't read it, but it wasn't emphasised in the document for me.
No, I'm agreeing with you. I think we need to bring that to the fore.
Okay, so I've got hands up from Alistair, Amir and Abby. I think it's in that order. Alistair, do you want to go first? Or Abby, were you raising a point about this issue?
No, it was just to pick up on a point that Trish raised about time to address
right, yes, sorry.
Address feedback. Because I think it's really important that people are clear that the whole purpose of consultation is to hear what people are saying and what their concerns are, and to take those into account, and as part of the decision making, or as part of how we shape the proposals before a decision is made on them. So in terms of the consultation, we'll obviously be reviewing the outcomes of the consultation while the consultation happens. So we'll be receiving sort of regular reports on the feedback during the consultation period. But in addition to that, within the timescale, there is a month built in to produce the consultation report, and then a further month to address the consultation report within the business case. So there is time, there is of course time built in to make sure that what people are telling us through the consultation is reflected in the final business case that's presented for a decision. I just thought it was important to make that clear.
Thanks, Abby. Alistair.
Thank you, Chris. I'm Alistair Bradley. I'm chair of the local medical committee. At the start of the discussion, Mike, you mentioned that obviously this has been driven by practices who sort of have outgrown the spaces. There's mentions obviously about the during the consultation process, the practices will have to do the quality impact assessment for their own patients. And there's comments in the document about this is a capital bid, and there's comments obviously about project fees, removal fees, etc. So one of the questions, or I was just thinking about the risks, is we've had some changes to the proposals because some practices have pulled out of this. So what are the risks, and when are the risks for the other practices might get to a certain stage through this consultation process and actually say, we don't think this is appropriate for our patients? I accept everything that's been said about the consultation process and the need to engage with patients, but this is driven by the practices, and presumably the practices there is a risk that the practices could pull out at some stage.
Absolutely, and we're very, very focused on that. There are many risks along the route. We have consultation, we have practices confirming that it is their intent. We have planning permission to obtain on buildings. There are many significant tests along the way, and we've got to meet the requirements of HM Treasury in terms of the parameters for the money being spent by December 23 and producing a return on investment. So there's many sort of hazards along the way that could mean that these schemes don't happen. We're very realistic about that. Well, our challenge is to mitigate those as far as possible, but it's not at the blind expense of we must get this through. So we've got to make sure that in all of those cases it's the right decision. In terms of capital and revenue, we've made an assessment of affordability, and we continue to update the benefit to cost ratio that's produced by the schemes, notwithstanding we've got some practices decided it's not for them, which reduces potentially some of the benefits, but equally it reduces some of the costs because we don't need to build for them, but it doesn't release money from their existing buildings. So it's a lot of complexity, and that's what we're doing at the moment, is just running through those and keeping a very, very close eye on those risks. But you're absolutely right, it is ultimately, if a practice, even if every other factor aligns, if a practice says thank you, it's not for us, then it can't happen.
Thank you. Thanks, Mike. Amir?
Yeah, just going back to I'm sorry, I'm Amir Afzal. I'm a governing body.
Thanks.
GP. on the CCG. Just going back to the travel and distance, it just occurred to me that one of the unintended consequences of that could be greater home visits again for GPs, which are neither satisfactory in terms of examining people in those situations, nor a very good use of the GP's time, unless there's a specific reason. And the trend has been over the last 20 years, or certainly since I've come into practice, for home visits to decrease quite dramatically unless, you know, for palliative care or people who generally can't get there. In this part of the city and the populations that we're dealing with, I would imagine that private transport wouldn't be as available as in other parts of the city, and neither would be the option of catching a taxi down. So it's just a thought, I think, that we need to be cognizant of that.
Okay, thank you, Amir. So are there any other points that anybody would like to raise about this more generally? Okay, I've got no further hands up. So before I just, oh, Jackie.
Sorry, just to Judy, sorry. Just to talk through about, just before you go on to the recommendations, what the next steps might be. So obviously if the PCCC is supportive of the recommendations, we need to conclude the NHS England assurance process. Obviously there are practical things we need to put in place in terms of going out to consultation, as Lucy has outlined. There is the timetable to conclude the consultation as outlined. And I think you mentioned at the beginning just about because this committee will no longer exist because the CCG ceases at the end of June, the assurance going into the new ICB structures. So there will be two committees responsible for reviewing the next stage of this. So the outcome of the consultation will need to go through the quality committee, who will have the engagement duties that sit with it. We are looking to put in place a local assurance that can feed into that committee, because our local arrangements through our speak committee will cease. So having some local assurance with people that have been involved to date, that will feed into the quality committee, who can make a recommendation to the ICB board. So that will be about have we concluded the consultation appropriately? And then the second will be around you know, if that's the case, what we actually take through as our final outline business case, and that will go through the Finance and Investment Committee of the ICB, again with a recommendation to the ICB. So I just wanted to outline that although the CCG will cease to exist, that we've agreed the governance route for the next stages.
Thank you, Jackie. Yeah, that's really important at this stage, and that we've got a commitment in terms of taking this forward, because, you know, the consultation timetable and so on, and we need to build, and not just build on, but have that smooth process through, with still in place with the principles of how important the consultation is in terms of feeding into that final document. And I can see quite a lot of nodding going on, and we have sought to achieve that, and we have got a commitment to do that. So thanks, Jackie. Judy.
I'm sorry, I didn't say who I was before, did I, Judy?
No, I didn't remind you. Sorry.
Running body. I mean, Lucy, you'd probably say that this would be too leading, but I just wonder whether there's an opportunity within the survey again to kind of, I know there's the question about, is there anything else that you think we should consider or would be, you know, an option, advantage and whatever, but specifically thinking, given that the pre-consultation identified that the notion of having other services in one place, such as mental health, etc., was valued, would you be able to ask something quite specific around that? You know, so you know, particularly if this went ahead, what would you be most happy to see as an opportunity from that? And then the other point, I think it's really good, and you know, we've grown to expect this in terms of the quality of the mixed methodology for the consultation. But I just wonder whether, in terms of the cost of having lots and lots of flyers and surveys printed, given that we've now got 4 clear potential kind of localities, if you like, is the potential to spend less on those printed surveys and things, and with practices to do more focus groups, you know, at different times and things during the day.
Yeah, thanks, Judy. We'll look at including a question about services. And about printing, I think we're only doing the consultation for 10 weeks, and ideally, you know, we might do it over sort of 12 or 14. The population are very deprived. You know, they're more likely to be digitally excluded. So I think in a more affluent population, yeah, we wouldn't have to have so many printed materials. And also that's compounded by that people aren't going into the practices as much as they would have done a couple of years ago. So ordinarily we could have had, you know, maybe you could have had more people in situ in a practice asking for their views when they came in, and we're going to do that. But I think footfall will be a lot lower. So I think we just have to use as many methods as possible. You know, I'd rather print too many leaflets than not enough. And I know, you know, it's not great in terms of cost and trees, but as long as we distribute them in the right places, and also you can use them as sort of to raise awareness and marketing as well. So, you know, somebody might see one on the 18th of July in a pharmacy and not pick it up, but then they might see it again a couple of weeks later and think, oh, what's that about again? And then, you know, by the 4th or 6th week, they actually might pick it up and then fill it in. So sort of a bit about like brand awareness. But yeah, it hasn't been exact science in determining how many we need printed. But we have taken advice from the community groups around, and the printed materials are seen as needed, and of course translated materials as well. So, but thank you, thanks for your feedback.
Thanks, Judy. Abby.
Yeah, so I guess just reflecting on the on the alternative you were suggesting, Judy, around more focus groups. We have built some of that in, and there are practices are keen to host either focus groups or sort of talking tables, having people there to engage with people. I don't know, Lucy, if you feel it's worth seeing if we can put even more in.
Yeah, we'll do, yeah. So yeah, lots of in situ stuff in practices and face to face, yeah. And the community groups have a role in organising some of that community face to face work as well, yeah.
Okay, thank you for that. So just before recommendations, I just wanted to say what a fantastic opportunity this is for investment in some of our poorer areas with quite diverse communities. And I appreciate it's quite difficult to meet all the requirements of this, but I feel assured about our consultation process and the learning from the pre-consultation as well, which will make a big difference to that. So it is an advantage to have this investment in the city, but getting it done in the best way we can with the constraints available is so important to us as this committee and for Sheffield, you know, wider Sheffield and its population. So thanks for commitment and involvement in that. And I know that it will be taken forward in that way in the future. So the recommendations about considering the comments made by the Health Scrutiny Subcommittee, which we've done, approve the draft PCBC consultation plan and consultation document, and approve the consultation on the PCBC. It's quite difficult to say that. Are set out in the consultation plan. So can I take it that you approve those recommendations? Thank you. I apologise. I'm getting nods, so I'll approve those. Thanks, Karen. I apologise that I've gone over, but I think it was important that we needed to get more of the detailed conversation and considerations for this. So I don't know who was saying, can we be quick? It was Trish, I think, but I've not achieved that on this item. But so if we can move then to the next item, which is the application to merge Sandington Medical Centre with Walkley House Medical Centre. And Abby, if you want to take us through that.
Thank you very much, Chris. Yes, so this is an application to merge two practices together where the contracts are already held by the same contractors. Sandington Medical Centre and one of the sites of Walkley House Medical Centre are co-located within the same building as a purpose-built building that houses the two practice sites. Walkley House also have another site at Walkley. So we are currently looking at two sites, two practices with 3 branches across 2 sites, just to make things slightly confusing. The previous single-handed contractor at Sandington, Dr. Sharma, wished to retire, and the partners at Walkley House Medical Centre entered into an agreement with him to vary onto the contract and then take over that contract from him. He retired at the beginning of this year, as did his wife, who was a practice nurse, and the practice manager. And since then, Walkley House have been operating both practices. They now, after doing a considerable amount of work and public engagement or engagement with their practice population, are seeking approval to actually bring those 2 sites together under one contract, so they can manage the patients as one list among other things. The merger, because there is no significant service change impact in terms of distance to travel or any other significant changes. It wasn't deemed that this needed full consultation, but the practice have, with support from Lucy's team, the engagement team, have undertaken quite a lot of engagement with their practice population, and the practice population, obviously, that was formerly from Sandington Medical Centre. I think it's fair to say that there are some concerns from patients formerly registered at Sandington Medical Centre that are reflective of how Dr. Sharma's practice operated previously. I think that Dr. Sharma's patients, because it was a single-handed practice, experienced an unusually high degree of continuity of GP, and also an exceptionally high degree of access. And I think it's probably worth saying that while those are extremely valid concerns, that would decline. The impact of Walkley House taking over this practice as opposed to any other practice. It's not different with Walkley House taking over this practice as opposed to any other practice. Walkley House actually do quite well on the GP patient survey in terms of experience and access. So it's not specific to this practice. In terms of service change, Victoria, you asked some helpful questions earlier in this week to clarify some information in the paper. So I wanted to pick that up here because the paper provides details of when the paper does provide details of when the practice is open, but it doesn't provide details of when appointments are available. So we can clarify what those are. So in terms of the Walkley site, appointments are available from 7 till 11:30 and 2 to 5:30 on Mondays, 8 to 11:30 and 2 to 5:30 Tuesdays, Wednesdays and Fridays. Then on Thursday, appointments are available between 7 and 12. At Sandington, appointments are available Monday, Tuesday, Wednesday and Friday, 8 to 11:30 and 2 to 5:30. And then on Thursdays, 8 to 12. However, the practice is open until 3 p.m. at Walkley, but not offering any bookable appointments during that afternoon time on the Thursday. What they are under discussion about at the moment is actually offering appointments until opening until 6 p.m. every day of the week, with appointments right up until 6 p.m. Patients, however, can the practice's call centre is located at Sandington, so patients can continue to go in person to Sandington on Thursday afternoons, and they can call and speak to someone at Sandington as well. That is not ideal, but we are obviously working with the practice around them being able to open until 6 p.m. 5 days a week, which is the direction of travel we're supporting. But practice do not actually close for a full half day on Thursdays. I don't know. I think that's a summary. We having done some work around this as part of the merger committee, our decision is to recommend this as the appropriate approach to PCCC. So I'm happy to open it up for questions now.
Are there any questions for Abby about this merger? Victoria.
Thanks, Chris, and thanks, Abby, for responding to the questions. I suppose it's, as you say, recognising the direction of travel, thinking about not only the current requirements for providing enhanced access, extended hours DES, but the enhanced access moving forwards, because obviously the paper says, I think it was within the proposal, that patients will benefit from extended opening hours, which sort of felt a bit more of a definite statement, whereas then further on it said it was being considered, and I just suppose it was just to be clear at the point of considering it today where the discussions were at, really, and I guess whether actually it's correct to sort of approve the merger, or whether, for example, you would say that actually you want to complete those discussions with the practices about their opening hours and access before the formal merger is actually supported and agreed.
They already do benefit from extended hours, because it's come to our attention that previously Dr. Sharma did close from 12 on a Thursday afternoon, although we weren't aware of that. So there are patients already do benefit from extended hours, which is what was being referred to, Victoria. But yes, we will pursue those discussions, and you're right, I think with enhanced access that will gain further focus.
Okay, Alistair.
Thank you. Yeah, I mean, just the comment about trying to delay this merger, in terms of what Sandington are actually doing, Walkley Health Centre are actually doing, they're not actually breaching any of their contract terms issues, and therefore there's no, you can't issue a breach notice on this. So this is not something that should be holding up a merger that is essentially, happened in terms of they've taken over the contract, they've vied across onto the contract. It's something that the practices want. It's something that obviously the CCG want. It's something that the LMC support as well. I accept there are issues around the access, and there may be discussions then through the extended access, because the statement does say that you are allowed to consider extending services in hours as part of the extended access DES as well. So there are opportunities around there. But in terms of pausing and gathering more information, there's actually nothing that they are doing contractually that is incorrect or a breach of their contract. And therefore, in terms of that, it shouldn't hold up the decision.
I think my point was possibly more about Sandington than about Walkley, Alistair. Because I think there is a question there, isn't there?
Yeah, of the hours, I accept that. But if they're sort of offering that service, even if it's till 3 o'clock, and that's where their hub is in Sandington, and they're offering that to the same patients.
Okay, thank you. Is that okay in terms of? I don't know if in terms of the issue. So it wasn't about a breach, but about the operation of Sandington and Walkley. Is that right?
So as part of contracts, as part of their core contract, practices are required to ensure that patients have access to services. Alistair's point is that they do. And also in terms of the primary care network DES, there's a requirement around reasonable access and not closing for half days on Thursday afternoons. And the practice don't. I think Victoria is suggesting that we be seeking conclusion of the point on full access at the Sandington site before approving the merger. My personal opinion is that we've got a lot of commitment from this practice to work on this, and therefore if PCCC were willing to approve it with noting that the work needs to be concluded to make sure that that further access is provided on the Sandington site as swiftly as possible, I think that would be my personal view is that would be the best outcome, but I leave it to PCCC to make that decision.
Victoria, as you raised it, would you be happy with that so that we can make a definite point about it? I'm concerned to obviously approve the recommendation in that it's our last committee and the rest of it seems quite in order and appropriate. But if we strengthen, you're saying there was some difference in the wording between identifying and providing. If we can strengthen that there needs to be an increase in access to services, is that, or we can check the wording with you?
I suppose as Jackie mentioned earlier, whilst this is the last meeting of this primary care committee, these decisions will continue to be made in future. So if a decision wasn't made today, you know, those decisions will be made in future. It's not that this is the last opportunity to do that. I think it's just the comments as I've made them to Abby. I think about, as I say, the paper and the proposal specifically says patients will access from longer opening hours. And whilst I can appreciate that there's ongoing discussions with the practice, that's a very definite statement rather than there is commitment to look at it, which is not quite so definite. And I suppose it's just been really clear the basis on which the merger has been agreed. That's the comment I'm really trying to make.
Jackie, do you want to come in on this? Are you okay, Mark? Because I think Jackie wants to come in on this specific issue. Or did you want to do that as well? Okay, Jackie.
Yeah, I think having read the paper and what's in here, I would agree. I don't think there's sufficient grounds for us to pause at this stage. I think we can be clear, as you said, Chris, in terms of you know, the commitments that they've given, and we'd expect to make progress on those commitments. I think, you know, it's the onus is on us to support practices to be in the best position to improve their access, and I think the proposed merger would allow these practices to come together to you know, improve efficiency of delivery across the two sites. And I think they'd be in a better position to address access if we supported them rather than put further barriers in their way.
Okay, thanks, Jackie. Mark.
Okay, I've got an apology. I'm afraid I've missed, it says the paper will follow and I've missed it arriving. So I was sort of trying to get my head around it, which would be my responsibility, not yours, I'm sure.
It did roll on in the end at the bottom of the papers, Mark, so. All
right, well, I've obviously missed it. But the, can I just ask then, just for clarity, because obviously in between these two practices is a great big valley.
Oh, yeah.
Yeah.
The two sites, yes.
Yes, in between the two sites, there's a great big valley. So the proposed merger will have no direct effect in terms of patients having to walk across, down and up at the other side. There'll be no effect there at all.
There is absolutely no intention to close the site at Sandington because Walkley House already have two sites, one at Walkley and one which is within the same building as the former Sandington practice, and they will continue to operate those two sites.
Okay, fine, thank you.
Okay, so We have recommendations to approve the application, which I'm minded to do. I recognise Victoria's concern, but I think in terms of all the other issues, it would be more straightforward and perhaps even enhance them getting this matter sorted more imminently, if you like. But I would like to put some assurance in for the next, as we hand over, that is particularly checked up and, you know, meet Victoria's concerns. Is that okay? Is everybody okay with that, to approve this merger with that amendment? And also, there is the other part of that is that the recommendation is the practice continues to review and measure the impact of the change and to work with the quality and engagement teams to further mitigate against any other issue that might arise post-merger. Okay. Jackie?
Yeah, happy with that. Can I just make the point, because we've lost a couple of people, that we are still...
Oh yeah, I wanted to point out that people have had to go to Quack.
Yeah, but we're still quorate to make that decision, so...
We are, oh good. I was just going to check. So Judy, Alan and Trish Edney, we had a conflict in meeting times and there's important issues on both agendas. So we started this earlier and I've somewhat run over our timing. So just to note that I think they left the meeting, Karen, you probably spotted it at, was it 2:32, about 10 minutes ago. Okay. So yeah, we are still quorate to do that. So if we can note that decision. And if we can then move on to the next item, which is the Primary Care Committee final report. So Abby, did you want to pick this up?
Thank you, Chris. Yes. So PCCC approved an extended annual report up until the end of November in January. And what we agreed then was that we would provide a final report that covered the period up until the end of the life of the CCG and the transition to the Integrated Care Board. So what is in front of you today is that final report, which summarises the work of PCCC in that intervening period.
Okay. Did you want to raise anything about the reports?
Nothing in particular, no. Thank you.
Sorry, I think we also wanted just to use it as an opportunity to reflect on some of the things that we've done since its inception in April 2016. I joined in 2000 and I started to chair it in July 2017. So I think the learning points in there, you could also say, turn them into things that we've actually, yes, learned, but also achieved by a number of actions that have made a difference in terms of those learning points. So I don't know if we've got any comments from people before I say a few things about, well, just it's the last meeting and the last public meeting, we've got the private one next, but for public record about some of the things about this committee, just to remind you, it was set up because of conflicts of interest in an organisation that was run by primary care and general practice and so on. And it was a collective decisions about reviewing planning and procurement of primary care services and commissioning decisions that relate to that. So I came into it, I'll start with me and then people could join in if they would like to or not. I came in and we were in the middle of a consultation about urgent care, which was really difficult. And as part of that wider feedback, we decided to take a different approach with this. And I think the approach we took was much more practical engagement, discussions, setting of the agenda as well. So we're right back to the consultation, where it's not just a set of things that we're asking if you like them or not, but going right back to what is it we need and what are some of the options, and having some input at that really early stage. And I think, and that process was really successful, and we were able to go forward in terms of that wider agenda and how we managed it, with support from wider organisations and certainly the patients and public. But I think from that, we've really built on how we engage communities and how we're proactive with that, and what difference that can make, and it does make in terms of outcomes. And so Lucy's team, you know, fantastic work, and I've got awards for it. And we set this off before COVID, but in COVID, with all the inequalities, that's made a huge difference to how we manage COVID, and also recovery and the vaccination process, the whole set of things that go with it, and issues about inequalities that were brought into sharp relief with. We knew a lot about inequalities, but the learning from COVID and the feedback from the engagement made a huge difference to that. So, and, you know, the work of Speak and the work of Quack, we were engaged across other groups in the learning from it and how we took it forward. I think the other thing for me has been about the practices, and I feel really proud to have been involved. I'm getting emotional, it's ridiculous, involved with the practices in Sheffield because of that, such a commitment in COVID, you know, such an unprecedented, you think back to the start of it, and really people at risk, and sort of their flexibility and commitment to how we might provide a service in Sheffield, how we might meet the needs of the most vulnerable groups. And that played out throughout in terms of how we got protection gear in place and relationships with dental services and procuring some of our own when we didn't have the supplies, but also in terms of vaccinations, and people have got, you know, the practices already have got great relationships with their communities. There's a lot of trust, and we could really build on that. So I know I say it at a lot of meetings, but that was so successful. And of course it is, we've got the most vaccine uptake. And then, you know, just before Christmas this year, wow, people were up and running those booster sessions in Sheffield and dropped other things and really did that. So I can't thank, you know, those colleagues right across the CCG in primary care, but also all the practices and the partnership with local authorities, with ambulance, fire service, and particularly the communities. And just the last thing is for me, how the Inequalities Agenda, I think I joined the CCG in 2017. There was a lot of points raised about inequalities, but I think we've moved on to look at, well, what I'm thinking of primary care, what is it we can do in primary care that can make a difference? And certainly we've had a lot of sometimes quite a heated discussion about what's going to serve the best, because it's not always straightforward, and things that we think are okay can actually make some of them worse by an offer for everyone that the more marginalised don't necessarily access. And that's played out in this discussion we've had today about the estates. And I was so pleased at the last meeting that in terms of the plan we've come up, there was so much support across this group for that in really practical issues, which I look forward to seeing carried forward, because there's a huge commitment in the ICB for this agenda. So as a public health consultant, you know, I'm really pleased that we got there with that, but that's not without a lot of people thinking about this and looking at what might be the best for our Sheffield community. So it's turned into a bit of a speech, which I didn't intend, got carried away emotionally. But so just any other comments for that? They summed up, as I say, in terms of learning, I think, in that report. And we have learned and listened. You know, I've changed my views, definitely. And I've learned a lot. And some of the things we've done in terms of that have come top down, like the network structure, took a lot of work in getting that in place and trying to make sure that fitted with what patients needed in partnership with the GPs. So that was quite an achievement, I think. So yeah, I'll finish saying that and stop speaking at you. Thank you. Jackie and then Mark.
Thanks, Chris. So no, absolutely concur with your assessment of the work of this committee. I think what has also worked really well is the interaction between the committees. So I think the assurance that our patient, Mark, you can roll it off to our Speak committee has given into this committee, the interaction between this committee and the quality committee. I think it has really benefited from, although GPs are not voting members, they've obviously contributed to the agenda and the LMC as well, and then also having the scrutiny from Health Watch and NHS England. So it's felt really affected because of the diversity of views that we have on this committee. I think we've still got work to do to think about how we take some of that forward into the ICB. So although we've got an outline structure as to ultimate governance, how we get those voices to influence some of the decisions, I think we still need to work through. Abby and I were having a discussion about that earlier. So some more detail to work through, but really, you know, a thank you from me as someone that's you know, been an officer bringing things forward to this committee. Really positive, you know, not always easy discussions, as you say, you know, quite a bit of challenge back, but really helpful in terms of determining and helping our thinking. And particularly just want to say thank you to you, Chris, for your chairmanship of this committee. I think you've always kept it quite real. So not a stuffy committee where we just go through a process, you know, making sure that we're hearing from everyone. So thank you.
Thanks, Jackie. That's kind of you. Mark. Oh, Jackie, you missed the audit committee as well. It's coming to the primary care is featured a lot in the audit committee because I'm a member.
Right. Yeah. No, I think I'd agree with what you're saying, Chris. And I'd also like to thank you for chairing this committee and your commitment to it, frankly, in terms of the last few years. I think the thing and I think Jackie mentioned this, but what worries me going forward, and this is a sort of compliment to this committee, is that in this place we've had quite honest and sometimes robust discussions, in particular with Health Watch and the LMC. And somewhere we have to have those discussions. And and I think it's really important that we've been able to have those here because it's helped us. We haven't always agreed, but it's helped us understand where others are coming from. And that's crucially important if we're going to do best for Sheffield. And I worry going forward, and I hope it's obviously not for me or you, Chris, to be, or Amir to be thinking about, but quite where the voice, for example, and Alistair, you'll be so surprised that I'm saying this, but where the voice of the LMC will be heard at place level, because I think there's a real difference between people who are paid to work within the new place structures as part of the NHS place team, having a place on various committees and feeding in, and actually organisations that are going to come along representing an independent or particular perspective where actually they're not employed by, within the new structures. And frankly, we need that. And I'm sure that there'll be people who are concerned about this, but it's going to be, at the moment, I'm not clear quite how those will play in a similar powerful way in terms of sort of local governance.
Thanks, Mark. Abby.
Thanks, Chris. I just wanted to add my thanks to you and to the other members of the committee. I joined the committee in 2019, so I've been working in primary care properly since December 2018, and I think it's fair to say that during my time we have dealt with some really quite difficult issues and some quite contentious ones, but that and during that time also, I think the primary care team's undergone an awful lot of change. So I wanted to thank all the committee members for their support and tolerance during that period, but also just to acknowledge all the members of the primary care team, past and present, who have been so dedicated to supporting primary care in Sheffield.
Thanks, Sabby. Amir?
Thanks, Chris. I'm going to carry on building this pressure up so that at least one tear comes out of you. Right.
It's nearly there by myself.
I'm just grateful for the way that you've carried on the committee. There was, before your time, there was debate as to whether there should be a GP or any GPs on this committee at all. As there were other doctors around, such as the medical director, the LMC representative, etc. But your predecessor took the decision that what you needed was informed decisions. And I'm very, very grateful that you allowed me and Nikki Bates up until recently to present that frontline view, not from an LMC point of view or a medical director's point of view, but as bog standard working GPs. And I've always felt that the views have been taken on board. So, and again, like Mark, I have great fear as to what would happen as we distance between the coalface and those who make those decisions. But hopefully we can keep the place as they keep telling us. So thank you.
Thank you. Thank you, Samir. Alistair.
Yeah, I mean, I'd just like to obviously thank you, Chris, for the work you've put in chairing this committee. In terms of Mark's compliment, we don't receive many at the LNC, so I'll take that and also reflect on the fact that I think that, we do all work in different areas, and it's been trying to work together, not in our silos of, representing a particular organisation or a particular population, but actually trying to work for the greater good of the patients in primary care. And obviously that does require the inputs of, doctors, nurses, healthcare, public health, public and all of those. So, it's a different forum. I think it's been a very good forum for debating and sort of approving primary care services within Sheffield, and I think as a committee it has worked very well, and as Mark said, there is debate and we do have differences, but actually those differences are sort of we still get outcomes from this committee. So I think overall, the way the committee has ended up structured and, its decision making, I think has been, sort of a commendment to the CCG in doing it this way. And I think, like everyone else, we're concerned about how structures will look in the ICB. We're talking here about, just talking about the transformation hubs, and we're saying, well, at the moment we've been looking at this as the primary care committee, but part of that is going to go to the quality committee, part of that's going to go to the finance committee, and actually we sort of did it all here. So, I hope we can all recognise that and all push at whatever level we can in the ICB to maintain some sort of structure like this for Sheffield at place, and for primary care specifically. So thank you, everybody.
Thanks, Alistair. I agree totally with the comments that other people have made about that future structure and how this has worked, because we had to be robust, but I think not at the extent of not getting the best we can from the decisions for Sheffield. Jackie.
Just in terms of a suggestion then, it might be worth, Chris, if you write to Emma Latimer, just from this committee, just outlining some of those concerns and the value that we've had from the type of membership that we've had on this committee. And I can certainly definitely beat that up as a separate conversation, but I think it would be reinforced if this committee wanted to write to her.
Yes, I definitely will. I've got a meeting in my diary with Emma, but not till July. So I wanted to share some of that then, but I'll write to her as well. So thank you very much for that. And thanks for your feedback and the comments. But yeah, reflecting back on it kind of gave me some insight in that it's going now. This is it. So is there any other business? We've run over quite a bit as well. In terms of escalate any messages to the governing body, there is the consultation. Can we do that still? Or I'm not allowed to do that in that we're going? I will.
So I was going to say we haven't got another governing body, but
we've got no governing body, Chris.
So we've got a meeting.
Where can they go to then? ICB governing body? Is there some, yeah?
Well, there's the first trust board, but the papers are kind of all agreed for that. I would suggest.
I've just put it in the letter to Emma then.
I think that's probably.
I wanted about the consultation really. I wanted to do something other than this last set of minutes to highlight, you know, that commitment and where it's going. Can we do that through something else?
So I think because Emma's taken on the board level position as place director, I think you can ask her to agree how to take forward our thoughts.
Yeah, so I'll talk to you about the overall PCC and, you know, that voice and influence and good outcomes that we've brought, but also specifically about the consultation as well, and as it's ongoing and really important for Sheffield. Okay, so thank you for anybody who's been listening or will be listening in the future, and thank you for your input. And